Great. Okay. So yeah, so I'm gonna actually kick off, and I just want to just remove this from the topic because it always blocks my slides. Great. So yeah, so as Lucijo has mentioned, colleagues, that we will essentially be moving ahead from our webinar, which was around about a month ago now, where we looked at the clinical approach to mild asthma. So we're moving across the stepping ladder now with regards to asthma care and management. And we're actually going to be looking at what is defined as moderate asthma, as well as severe asthma. So just to move on ahead again, just to give the definition of asthma for those who might have not been around in the previous webinar. So asthma is the most common as well as chronic non-communicable diseases. It affects close to almost 300 million globally. And it's the definition of it is that it's characterized by variable respiratory symptoms, so they come and go, and these symptoms are such as a wheeze, which your patient might actually even refer to as a tight chest, shortness of breath, a tight chest, as well as a cough. And this is also now associated with what we call variable expiratory airflow limitation. And again, variable means it's comes and goes. It might be there, might not be there, depending on when you do the lung functions. And well, we do know all forms of asthma patients, be it mild asthma to severe asthma, these patients all have airway inflammation. And what's also important with regards to know about asthma is that people with asthma often have periods where the symptoms are worse, and the airflow obstruction becomes worse. And that's what we refer to as what we call exacerbations. These are also referred as, asthma attacks or flare-ups. And this is what you don't want. And these can be fatal. And asthma itself is, most of the morbidity and mortality is preventable. Especially now that we know with the new emerging data that's come on, and the data signal has been up there, since for a very long time now, that the use of inhaled corticosteroids can actually, prevent mortality in these patients. So I did include this slide in the previous talk again. I think it's just a nice reminder to see exactly the prevalence of asthma. This is, again, almost 10 years old now, this slide. And even then, it's not really accurate, but even then we do know that, asthma really affected Africa and sub-Saharan Africa. There were at least about 10 to 15% of the population were asthmatics. Now, this is a statistics that, as a South African, and with no offense to all the other guys that are in the same group, the Egyptians and the Philippines and the Fijians and the Mauritians, it's not a great statistic to know. This is the mortality data that's showed with regards to asthma globally. And you can see that, there are no asthma, essentially very few, if any, asthma deaths in high income countries. And this is a disease that's got a high mortality in low and middle income countries, and South Africa, as of 2014, we were the leading cause of asthma deaths. So this is a condition that's quite fatal. We are not doing well, and we do not do well as a nation on how we manage these patients, and I think it's important that we educate and so that we can address these issues. So what is asthma again, and generally what are the pathogenesis and what really happens? So the main issue with asthma is a combination of two things. You've got bronchoconstriction, you've got airflow limitation, you've got excess mucus production, and all these come together to give you essentially this sort of really, really, really narrowed airway, which is associated with the definition as well as the symptoms that we associate with asthma. And so how is there a link? So we mentioned that the main driver of symptoms in patients with asthma is inflammation. So inflammation has got a bidirectional sort of feel to it. It's responsible for your airway hyperresponsiveness, which in turn is subsequently responsible for and predisposes you getting airflow obstruction. And those two come together, giving you the clinical symptoms of asthma that we are aware of. So this is the GINA guidelines on the management of adults asthma, and this is 12 years and above. And you can see we went through this in the last webinar, but just a quick recap again that asthma care and medication involves various steps. You need to assess the risk factors, modifiable risk factors. We need to look at for comorbidities. We need to look at inhaler techniques as well as adherence. And importantly enough, we must always engage and make sure that we have patients that are engaged in their therapy, and what are their preferences and what are their goals. And then the second part of the armamentarium, obviously, is to adjust what we're doing, treat any modifiable risk factors, because those are actually quite contributory, and these become more important as I move on into the talk, especially with regards to asthma. You must look at non-pharmacological strategies. With a weight loss, avoid the cat at home, or maybe give the cat away, or maybe don't visit the cat as often. Asthma medication, as well as educational, as well as skills training. And then the last thing is just a review aspect of the arm. You need to review what are the symptoms, because symptoms affect the quality of life, and it's essentially that's what we want to improve. Exacerbations, any underlying side effects, and when we do review the processes, lung functions we come into play, and then again patient satisfaction. Now we talked about stage 1 and 2, steps 1 and 2. And these are the new the new junior guidelines of 2022. Also now, split the tracks into track 1 and track 2. Basically, track 1 being the control and preferred reliever, and track 2 being the control as well as an alternate reliever. So what are we going to be talking about today? So today we're going to be talking about moderate asthma, and moderate asthma is basically in between step 3 and step 4. These are patients who have got symptoms. Despite being on low dose maintenance inhaled corticosteroids plus LABA, in Gina, we're talking about formoterol, or it could be patients who are actually on medium dose maintenance inhaled corticosteroid as well as formoterol. So that's essentially what we talk about when you're talking about moderate asthma. This is the group of patients that we are alluding to, and this is the group of patients that we are referring to. So I think it's quite important before we move forward, and when we talk about moderate and severe, and when we talk about low dose inhaled corticosteroid as opposed to high dose inhaled corticosteroid, it's important to know exactly what do we actually mean. And this is a paper that was published in one of the respiratory journals in 2 years ago now. And they talked about the issue of inhaled corticosteroid in adult asthma. And they were advocating that, maybe it's about time that we, have a new therapeutic dose terminology, because this sometimes can be actually quite confusing. So what exactly do we mean? So if you look at this, is an important slide which focuses on what we mean by in terms of low, medium, as well as high dose of inhaled corticosteroids in patients with asthma. And this is what has been defined by Gina himself. And I'm just going to try and get a pin. Sorry, that I'll try to just get a pin going on. But what we can see here is that, we define low, medium, and high dose. First of all, it depends on the type of inhaled corticosteroid that you're using. So beclomethasone diapropionate, budesonide, which is commonly that we use in the state sector, which is referred to as Budaflam or the brown pump. Then there's also cyclophosphamide, as well as fluticasone propionate, as well as fluticasone fumarate and mometasone fumarate. And the differences in these inhaled corticosteroids are a few things. Some of them are dry powdered inhalers, some are metered-dose inhalers, and then the propellant is different. But I think it's quite important to actually understand in terms of, how do you actually define low? And depending on where you are, you can actually see most of these, inhaled corticosteroids, when we do prescribe, they usually prescribe in the region of about 2 puffs twice a day. So it's important, depending on what you find, 2 puffs depends device can deliver. So you can see, if you are using budesonide, for example, and I'll use this microgram. So if you're writing up, 200 micrograms, 2 puffs twice a day, that always actually almost takes to at least about 800 marks daily. So it's very important exactly that we actually know exactly, because they all come from contractions, and the high is for easy to reach the medium high dose. So it's very important to realize. And when you look at, fluticasone, for example, more than 500 marks is refined high, whereas that, is actually actually medium for budesonide. So I think it's very important that when we talk about it, and I refer to, step 3 or 4, low to medium dose, this is what I'm actually referring to. These are the steroid dosages that we are actually referring to. So just to move on that now, just move on.
You can use the arrows on your keyboard.
Yes, I am pressing them. I'm not sure why I'm not moving on. I've been using them. Let's just try.
Click on the slide first.
There we go.
Okay. Sure.
Sorted. Thanks very much. Apologies for that, guys. So now we need to come back to the next issue, right? And the next issue refers to actually how do we define severe asthma? And I think it's quite important that I just give a definition of that. We've just talked about moderate asthma. We talked about that's actually stage 3 to 4, and then obviously when you're on other low to medium dose of corticosteroids, and we have shown you what dosages we refer to when we mention those. So the European Respiratory Society, as well as the American Thoracic Society, define severe asthma as follows. Severe asthma is defined as an asthma that requires treatment with high-dose inhaled corticosteroids. And they give you a definition of that. So depending on what steroid you use, more than 1,000 mics of fluticasone or an equivalent, plus a second controller with or without systemic corticosteroids, to prevent the asthma from becoming uncontrolled, or as the asthma that remains uncontrolled despite this therapy. So the question is, what do we mean by inadequate control? So inadequate control is defined by any of the following. We look at symptoms, and we talk about symptoms, we talk about poor symptom control. And here we look at the ACQ questionnaire, which is the asthma control square. The higher it is, the worse your symptoms are. So any score of more than 1.5, or the ACT, which is the asthma control test, and that's in a score of less than 20. So these scores, there's this 1 to 5, and you ask the patient questions, and the patient should tell you how they feel, and you can actually score them quite quickly and easy to realize. And important enough is that when you go to either ACQ of more than 5 or ACT of less than 20, are not well or controlled according to the National Asthma Education and Prevention Program, or GINA guidelines, over 3 months of evaluation. There's a few things. 1, you must make sure that you're on high-dose steroid. 2, you're on the correct therapy and correct dosages. And you need that to prevent you from being controlled, or you're worse despite having that. And all of this correlates with control. Good control. It's also defined by frequent severe exacerbations and so these are patients who actually now have got exacerbations, so-called asthma attacks, require corticosteroids generation or ICU stay, and if you end up in ICU, you've been mechanically ventilated. That's intubation and ventilation. Or we talk about severe asthma. Now, severe asthma. It's also to ensure that to actually realize that there are various common diseases which are associated with severe asthma, and it's very important that we look for these as these can generally mimic mimic asthma. So the question is, what are these associated comorbidities or symptoms? So firstly, gastroesophageal reflux disease, is usually associated with microaspiration, and this can mimic asthma, right? And the symptoms for these are also similar: cough, waking up at night, as well as a tight chest. So we need to always make sure that if we're evaluating someone, we've got either moderate rhinosinusitis, right, and an upper airway of flow of limitations, all right, and that the symptoms of that are also that of mimic asthma, so including a cough, they might have a wheeze, they might have sputum production, a high PI is also associated with be compatible with asthma. And we've got we've got abnormal cord disease called, we refer to as vocal dysfunctions, who can have exactly the symptoms in keeping with asthma, not really getting actually given as where you would be able to diagnose a vocal dysfunction is via an ENT, we'll then obviously do upper airway scope, and then obviously anxiety. We live in a society, and we live in a times where there's a lot of things going on, and then these all could be anxiety provoking. But I must admit, anxiety always got lost. It's always important to make sure that we all the common things, and these symptoms. Now, there's certain comorbidities to address, which may be able to improve the underlying asthma. I think such as hello.
Yes, your network is cutting a bit.
Other comorbidities that we need to. Okay. Look. Is that a bit better?
Yeah, I've switched off your video, but I think continue. I'll let you know if we can.
Okay, move, just let me know and I'll be able to move. I can probably go to another area. So comorbidities or treatments of which may improve asthma, allergic reactions, so potential treatments in decreasing exposure, therapy, anti-IgE therapies, anti-IL-4. Encourage our patients to lose weight, and bariatric surgery is an option. Patients who've got aspirations, swallowing precautions. We need to obviously gastroesophageal reflux disease treatments, so H2 receptor antagonists, ranitidine, proton pump inhibitors. We can address that. And smoking is a no-go area for patients who are asthmatics. And we obviously we need to promote smoking cessation or vaping, and then any other autoimmune diseases which may mimic underlying asthma, which may also treatment may include non-steroidal immunosuppressive therapies. So when it comes to severe asthma, I've just given you the definition. This is what we're referring to. These are patients who are on step 4, step 5 of the ladder. These are patients who either have medium dose to high dose ICS, and these are the patients that who are on this therapy are still not getting better, and they've got ongoing symptoms. Now, there's a whole lot of other things that are referred to there on step 5, of which I will address as we move forward. So when we talk about severe asthma, it's always important to actually, ask ourselves, how common is this, in the asthmatic population? How many of them actually do have severe asthma? And the prevalence is actually quite, it's different depending on the where you're actually from, and the statistics from different areas and different countries. But the one of the most commonly sort of cited one is a study from the Danish guys, as 2014 already. But as you can see that the majority, it's a nice study, it's got a lot of patients, majority of their patients, asthma population, which is what we always find, is going to be mild to moderate asthma. And you can see they're close to about 43,000 of those patients. When you look at severe asthma, it literally averages anything between 3 to 10%. That's essentially where we know that these are the patients who in the total asthma population. And this is what they found in this study actually reflects and is important in terms of what else was seen in other countries. So when we talk about the prevalence amongst the asthma population, we're looking at least at about 3 to 10% at most. So now I can't talk about severe asthma, unfortunately, without actually talking about how we classify it, because that's important. And it's important for two reasons. One is, from a therapeutic intervention. And then obviously so that we can all understand what is out there that, you can offer patients with severe asthma. So just to start at the top, we know asthma can be early onset, there's late onset asthma. Diagnosis is varies on your symptoms, as well as lung functions, as well as exacerbations. And we've moved on now in terms of how we classify asthma. So we classify asthma into what we call T2 or Th2 predominant inflammation versus non-T2 or non-Th2 predominant inflammation. And the T2, the Th2, initially was Th2, and it applies to the immune system, the Th2 pathways. And there's various cytokines that are thought to obviously drive the asthma patients. So all I just wanted to know that we've got two phenotypes. We've got an eosinophilic phenotype, which is the T2 high or T2 predominant one. And then we have the non-eosinophilic type, which is the low T2 or no T2 as up. And that's refers to the T helper cells as part of the immune system. I'm going to spend some time on this. I know it's quite a busy slide, but it really is quite important in order for us to understand how do we actually manage patients with asthma. So I think what I would like to do is just to draw your attention on the pathogenesis. So the pathogenesis of asthma essentially, and I'm going to focus here on the most common form of asthma, which is the eosinophilic asthma, or what we refer to as the T2 or Th2 high asthma. And it's quite important to understand, because when we understand the pathogenesis, it actually really becomes quite easy in terms of us being able to in terms of us being able to talk about therapy and look about therapy with regards to this. So I think what I want to draw people's attention is I just want to double check. Mawele, can you guys see my mouse?
Yes, we can see your mouse. Thanks.
Perfect. Thank you.
Yes.
Thank you. All right. So I think what I want to try and find, just to make it clear, is that your precipitants for your asthma, right, or your risk factors are one. There could be allergens. Okay, that could be allergens from pollen and anything else like that. It could be irritants, and that usually will be smoking or cigarette smoking. Bacteria or viruses, which could be a triggers. Then we've got something new called Staph aureus super antigens, which are found in the nose. And then the last thing could be things such as infection or air pollution. Now, depending on which of your trigger, which could be an allergen, an irritant, bacteria, infection or air pollution, they all trigger different parts of the immune system. So we have the airway epithelium here highlighted in blue. And highlighted here in blue. And what we have then is various cytokines. So anything that's on immediately after the blue line, which is from on this line here where the mouse is going, is what we refer as upstream. And the important cytokines there are IL-25, IL-36, and the new one, which is TSLP, which I'll get to later. All I need you to concentrate is on that. And then the other ones are IL-33 and TSLP again. So those are the main pathways that are associated upstream. Depending on what happens, what we do have, as you can see with the diagrams, is that they then obviously stimulate the Th2 part of the immune system, hence Th2 high asthma. And then there you produce various cytokines. The important ones to remember, it's IL-4, IL-5, and IL-13. all of these processes, depending on whatever's triggered it and which part of the immune system, it ends up with one of all of these issues, right? You've got inflammation, you've got cytokines, you've got chemokines, and unfortunately it causes local tissue injury and what we call as airway remodeling, where essentially your airways become more stiffer. And then you have airflow obstruction, symptoms, and asthma exacerbation. So I think this is a very complicated study, and I really don't want to bore you down on all the details, but the main important thing is to just understand the various important cytokines, because they speak towards the relative therapy that we're going to be administering for these patients. So as we move forward, for this paper here, again, what I just really want to highlight is we know now that how do we classify the common cause of asthma? It's T2 high, or the type 2, what we call eosinophilic asthma. And we've got certain biomarkers. So these biomarkers assist us in actually confidently saying that this patient has actually got a T2 asthma as opposed to non-T2 asthma, because your therapy is vastly, vastly different. And all I really want you to focus on this one is the biomarkers. So when we diagnose asthma, and we're talking about now, this is a patient who's got severe asthma, they've made it to actually be seen by a respiratory physician. What do we do? So the first thing we do is we do a full blood count, and we want to phenotype our patient. So we do a full blood count, and there we're looking for the eosinophils. The blood sputum of blood is allowed, and then we look at it for evidence of eosinophilic driven inflammation. We look at the levels of what we call your IgE, so we can test for that in the blood. And then we've got something else new that's come on over the past couple of years now, which helps us also phenotype our patient, is also called FeNO, which essentially stands for fractional excretion of nitric oxide. And that what it does, it actually measures the IL-4, IL-13 pathway. So we know if that's up, we know that the patient has got T2, and then we can actually just do something called serum periostin. So those are the important biomarkers that pulmonologists will actually use to actually assist us in actually categorizing our patients to say this is a T2 high and this is obviously T2 low patients. And again, remember, these are patients now that would have been being seen by a specialist and a pulmonologist, and this is what we do extra in addition. These are not your mild asthma patients. These are patients that actually, as I said, that are being referred up. So it takes me to the next available thing. So what are the biological therapies that are available for severe asthma? And again, this was a New England Journal publication, which was published a couple of months ago. So it was this year, so this is very recent. And it looked at all of these things. And again, it's going to be a busy slide, but what I really want people to focus on is what I discussed earlier. So we talked about that you've got your different risk factors or your triggers. Then you have your epithelium. Now I talked about we talked about TSLP. Okay, that's thymic stromolymphopoietin, and that's actually seen quite actually in asthma, and we've got drugs for that. We've got something called tepezulumab, which blocks that pathway, what we call anti-TSLP. We told you that I've referred and I've showed you previously slide that IL-4 is also big, the pathway, interleukin-4. So we've got something called dupilumab, which is an anti-IL-4 receptor alpha agonist. We know that we can actually give anti-IgE, which is what we call omalizumab. And then the main ones, which is anti-IL-5, because IL-5 is an eosinophilic driver. We've got two drugs there called reslulimab and mepolizumab. And then we've got an anti-IL-4 receptor analog, which is dupilumab. And then lastly, we've also got more anti-IL-5, which works in different areas. So that's actually the biological therapy. When you talk about biologics are only indicated for patients who have got T2 high disease or T2 disease. And they actually work all the way from what we call upstream, as I explained it, or all the way downstream at the eosinophils, IgE, mast cells, and all those levels. So that's essentially where our asthma biological therapies come from. So just to get it done, so the key changes to these is that in the new GINA guidelines, now I've mentioned that the anti-IL-4 is not suggested if the blood eosinophils are more than 1,500. So we use the blood eosinophils as a trigger to look for these things. But we know that dupilumab now has also now been approved for kids and who've got severe eosinophilic asthma who are not on maintenance therapy. And important now, as we talked about the anti-TSLP, It's also now been approved, and it's available overseas. It's shown to have greater clinical benefit for patients with higher blood eosinophils, but there's insufficient evidence in patients who are taking maintenance systemic steroids. So how do we choose these things, and how do we give these things? Well, as it says, Gina breaks it down quite nicely for us. So omalizumab, which is anti-IgE, is a subcut administration, and the indications are for patients who are more than 6 years of age. That's the first one that's to come out, and it was at least in the early 90s that it came out, and it's for severe allergic asthma. You can also use it for other things such as nasal polyposis or chronic spontaneous urticaria. And then anti-IL-5 as well as IL-5 receptor. As you can see, there's different names there, and the other subcut, they can either be intravenous, and they've got different indications. More than 6 for mepolizumab, more than 18 for res, and more than 12 for benra. Again, as you can see, severe eosinophilic type 2 asthma, and he's also got other indications. And then the other two here, what I've just talked about now, is dupilumab and tepezolizumab. So what does GINA say? So how do we manage patients with severe asthma? Right, so GINA is quite clear. So first of it, so moderate to severe asthma, the other name for it, especially the moderate one, is difficult to treat, is you need to confirm the diagnosis. 2, you need to look for factors contributing to poor symptoms and exacerbation. So the usual stuff, make sure that we correct our inhaler technique. We make sure that the adherence is optimal. We exclude all the comorbid disease. We manage modifiable risk factors. What are the triggers at home or work? Is anybody smoking? Are there any environmental exposures? We know beta blockers are not good for asthmatics, and so are also non-steroidal anti-inflammatory drugs. And overuse of SARBs only is associated with worsening asthma, and anxiety, depression, and also social difficulties. Then the third part is to optimize management, right? Educate. Optimize treatment. Consider non-pharmacological interventions. Stop smoking. Exercise. People who are overweight, advocate weight loss and mucus clearance, and make sure that patients, especially respiratory patients, we always advocate influenza as well as pneumococcal vaccination, and then now with COVID vaccinations. And then we also have what we call non-biological add-on therapy. That's higher doses of LABA, higher doses of a long-acting muscarinic agent, or a leukotriene receptor antagonist, if you have not tried those already. And then there's also a trial of patients, if you really can't get a patient in, we consider a trial of high-dose inhaled corticosteroid if not used. Then you need to review your patient after 3 to 6 months. And there, it's quite simple. Is your patient with asthma still controlled? If yes, is still uncontrolled. If yes, then it's probably severe asthma. If no, can you continue stepping down oral? And if you do, you always start with the oral corticosteroids if you use that. But if you step, does your patient's symptoms be worse, then you can go back to the usual dose and severe asthma. And then these patients need to be referred to the specialist. And then what happens when these patients are seen by specialists is a whole host of things, which I'm not really going to bore you down to all the details. But basically what we do is we just make sure that we confirm the diagnosis is really true asthma. We exclude the asthma mimics, of which what I mentioned earlier. And then the next thing, we phenotype our patients. And how do we do that? We need to find out exactly, does our patient have evidence of type 2 inflammation? Because, as I mentioned before, biological therapy is only indicated for those type of patients. So we would actually do blood eosinophils, we'll check the sputum eosinophils, and we'll do a phenol. That's how we phenotype our patients. And then if we know that, look, the patient has got type 2 airway inflammation, then we'll try increasing the ICS dose for 3 to 6 months. And then obviously we'll go on to meeting and looking at starting biological therapy, which I've just showed in the previous slides. If your patient is an asthmatic, but they don't have evidence of type 2 airway inflammation, that's a different group of patients, a really more difficult group of patients, of which we really don't have great therapy for. But those patients we can always discuss on the Q&A, and those patients are usually more associated with more difficulty in management and symptoms. So biologics, how do we consider them? This is in the GINA guidelines, again, the latest GINA guidelines of this year. And as I've mentioned to you, I don't really think you should get really entangled of the names. I think as long as you understand what drug does and which part it addresses, I think that's important. So if you suffice to remember that there's anti-IgE, and that's the downstream, anti-IL-5 and IL-5 receptors, because those are the ones that stimulate eosinophil production, anti-IL-4, Those are all downstream, and then upstream is what we call anti-TSLP. So that's all that I would like you to remember. So that's what we would generally do with these patients. And then we have certain criteria, which obviously will help us to see that, which patient is eligible and for which one, and which one to actually start. The important thing is to realize is that once we've actually tried a patient, right, we need to choose one, and we need to try for at least 4 months and assess response, right? If after 4 months your patient's got good asthma response, you would then push on and you would continue. If they really don't have a good clinical response, there's one or two things. One is that you can really actually consider switching if they are eligible, or try other form of modality or therapy. And then we need to review response. Okay, once your patient is on these fancy drugs, we need to review response, and then you must continue to optimize the management. And we review these response based on all of these things. We look at oral treatments, what are the inhaled, and if we don't have actually, and the most important thing is if your patient does not respond to a biological therapy, we have to stop it because there's a lot of cost impact on it. And again, I will touch on that on the Q&A. So what about those patients that, are not doing well? Is there any other modality besides biologic that we can use? And the answer is yes. We've got something called now bronchial thermoplasty. This is an article that was published in the European Respiratory Journal in 2015. And it basically, is a new therapeutic option for patients with severe uncontrolled asthma. So I don't want you to focus too much. Just know that there's been 3 randomized controlled trials in the far right there, which has looked at this modality. But what I want you really to understand is that these were patients who were adults, were in high dose inhaled, which I've highlighted in red. These were adult patients who had high dose of inhaled corticosteroids across the different studies, and they had different forms of airflow obstruction, as you can see, FEV1 of more than 50%, and the other one FEV1 of more than 60%. So how does this thing work? Well, it's a very nice gadget and a nice tool, and it's done by interventional pulmonologists. And the way it works is that it's done via bronchoscopy. So your patients would undergo a bronchoscopy. Okay, the bronchoscopy then will be directed to target a specific airway. This procedure is done essentially in 3 sessions. It's the lower lobe on the right in the one session, and then the next session is the left lower lobe, and then the last session is the upper lobe. So what we do is we do a bronchoscopy. We then obviously target an airway, and then we can see that we then the bronchial therapist goes through the scope, and then we essentially will activate what we see here, heat activation onto the airway, and that's how it looks like. And it gives you the sort of thermoablation, and it's associated with reduction in your airway muscles, and is associated with improving symptoms. Is it really effective? We know that this medical therapy is actually effective in patients for more than 5 years, but there's a new paper now that was published last year, which shows that it's actually effective for up to 10 years in terms of efficacy. And how what does it mean by that? And as I alluded to this before, symptoms are very important in patients with asthma because they improve the quality of life. And as you can see here, that when you look at the ACQ score as well as the AQLQ scores, you can see that if all the symptoms were well maintained across the time from baseline till at least about more than 10 years. So I've said a lot, and I just want to summarize in terms of actually what we're talking about when we're talking about severe asthma. So severe asthma compromises 3 to 10% of the adult asthmatic population. The cost of care of severe asthma patients is estimated to be at least 60% of total asthma costs. So even though it's a small number in the general population, but to actually manage these patients costs a lot of the total asthma budget. And a sobering, statement is that, healthcare costs per patient for severe asthma are higher than those with type 2 diabetes, patients who've had strokes, as well as patients who've had chronic obstructive pulmonary disease. Severe asthma imposes a substantial burden owing to symptoms, exacerbations, as well as medication side effects. And I think the other important part when you're talking about severe asthma is that it's associated with profound consequences for mental as well as emotional health, as well as relationships and careers. Right. Thank you, Dr. Mawela. I'm going to stop right there. Thank you.
Superb, superb. Thank you very much, Dr. Ngwenya. I'm not used to calling you Dr. Ngwenya. Ayanda. This was quite informative, and I'm sure that we are going to have a number of questions and comments to engage on. Yeah, maybe let me start by asking you, what is there a relationship between mild asthma and severe asthma? In that, and maybe the basis for my question is whether severe asthma is preventable, or we do have patients who are just having specific predispositions to severe asthma, or most of the severe asthma cases are actually patients whom we did not manage well when they had mild asthma. So you can try and talk through, these key issues. Thanks.
No, thank you very much. And that's a very, very good question. So I think, the common misconceptions is that patients get labeled as severe asthma when in fact they've actually got poorly controlled asthma. So that for me is a problem. So if we don't manage our mild asthmatics properly, do we run the risk of them becoming severe? I think yes, you do, right? Because we do know that excessive, if poorly managed mild asthma, we know that obviously you run the risk of getting a recurrent airflow and airway inflammation, which obviously long term comes up with something like airway remodeling. So yes, there is a link, if not really well controlled, because we need to actually address these things from the start. Because as you can see now, if you progress to severe, the costs and the implications and the quality of life are actually quite huge. So what you really actually want to do is make sure that your patients in the mild, because majority of your asthma, 60 to 70% of your asthmas are going to be mild to moderate, very mild. So we need to be addressing that. The severe guys are very, very small, as I said, 3 to 10%, but they use a lot of other issues, and I think it's something that we really need to be careful about. Yes, so there is a link, because we need to do the basics well first before we can even address and get to the high end.
Yeah, superb, Doug. So maybe before I also go to other questions by colleagues, is then to ask, at which point do you decide to keep your patient on your inhaled corticosteroids, and what would be the few indications for maybe converting? I'm not sure whether we are adding or converting to oral corticosteroids. Yeah.
Okay. All right. So we, in general, oral corticosteroids are going to be used in patients with acute exacerbations. So these are the patients that have got a tight chest. They've come into either the clinic, the district hospital, or any evidence of primary health care. We'd like, obviously, to give them oral corticosteroids. Now, the problem with oral corticosteroids, especially used in long term, is the side effects associated with them. And we know that systemic oral corticosteroids, yes, they wipe out a lot of information essentially quite quickly. But the problem with that is that, and it makes you feel well very quickly. The problem with that is that long-term use is associated with side effects. What are those side effects? The side effects is one, in predisposition to having diabetes. So that's the first thing. The second thing is going to predispose you to obviously getting hypertension. Third thing is going to also predispose you to getting recurrent infections. And in our environments in South Africa and in sub-Saharan Africa, the issue of pneumonias and recurrent tuberculosis come very high on the agenda. And then lastly, it also obviously eats away at the bones, and it can give you osteoporosis. So, you get high risk of fractures. So all the metabolic sort of complications associated with the use of long-term corticosteroid is what actually makes us move away. We actually don't want to be using those, to be honest. We actually only want to be using those in the acute setting. And yeah, so that's essentially how we manage the use of oral corticosteroids as opposed to inhaled corticosteroids.
Yes, and I know you're not a pediatrician, but I'm not sure if you do see kids because you are a physician. But there's a question around, how would you suspect? I mean, I'm not sure, because we are still going to have a topic on this, but you'll share your views and then we take it from there.
Yeah.
A child of 2 to 4 years old, how would we go about to suspect asthma? Though I think it's a follow-on talk, but I don't know if you want to say something about children and asthma. Yeah.
Yeah, no, thanks. So I haven't seen children in a very long time, to be honest.
Yeah.
But in a child of 2 to 4 year olds, I mean, I still do remember some pizza, but I'd like to give a disclaimer that I'm not a pediatrician. But usually in children 2 to 4 years, the children 2 to 4 years will often present with chest symptoms and a wheeze. And generally that age group is usually susceptible to viruses, and it's usually RSV and the rhinovirus. They generally precipitate what we call bronchiolitis in these kids, which is what is responsible for a wheeze. So they not really actually have asthma, but they obviously have recurrent chest infections due to viral infection, especially in winter. So bronchiolitis is something to think about. But in the absence of all of that, how would you actually make a diagnosis? I think the symptoms are quite important, as we talked about. The symptoms in adults and in kids, and the older kids especially, are quite similar. So I think the parents will generally give you the history. The child, his chest makes a noise mainly in the early hours of the morning or mainly at night. They become very short of breath. They become very lethargic. They can't really, get involved in a lot of activities that they used to be, especially if they've been walking around at 3 to 4 years of age. But yeah, so I think it's for them, it's a combination of things: viral infections that you need to sort out, that they are predisposed to at their age. And then obviously with it's actually really true asthmatics. Yeah.
And the lung function test is a specific age where it can be indicated, or any child might be eligible for that?
Yeah, I think once the difficulty of I can imagine of pediatric pulmonologists in lung functions, obviously it requires a lot of coordination, and that becomes very very difficult in kids. But there are lung functions. I can't tell you exactly how age, what's their start, but I do know when they do have lung functions, they also have the spacer to assist them with the coordination. And yeah, but there are indications, as I said, I'm just not sure.
Yeah, I've seen guidelines generally would use 6 years, and above.
Yeah, it's round about there. Yeah, it's round about there.
The below 6 years is a more difficult group to deal with. Yeah, so again, you're not an obstetrician, but there's a question around asthma and pregnancy, the interface between the two, and whether there's a specific considerations around pregnancy and asthma.
Okay, no, thanks. I mean, I actually do see quite a lot of pregnant people, patients who are coming in with quite worsening asthma, and that's quite simple. I think pregnant patients with asthma have a higher risk of reflux. So they have microaspiration, which, as you see, we mentioned there, is one of the common comorbidities associated with asthma. And generally, these patients' asthma become quite worse, and especially the more at far down in their pregnancy at term they become. So what we generally do for these patients is that we trial them on a PPI, which is not teratogenic, and most of them that actually really sorts it out. So I think there is a link. Pregnant patients at risk of microaspiration and worsening asthma, and we generally would advocate for the use of a proton pump inhibitor, something like omeprazole or lansoprazole. Yeah.
Yeah, it sounds like getting to the cause is more important than the treatment, because treatment are many, but pinpointing where the issue is quite important. Let's see if we can take some live comments or questions. Siane Socrates, yeah. Siane, you can, yes.
Okay, thank you. I just want to thank you for the comprehensive, empowering kind of talk, and drawing the differences. Some of us, we just treating acute serious asthma attack and so on, but now we're getting the science behind it, and I think it helps us formulate a better approach, and that's just my comment, and I'm hoping that we shall be able to see the slides at some point. Thank you.
Thank you.
Thank you very much. Thank you.
Thank you for that. Let's try and get Samuel Risenga. I'm not sure if you have a question, Samuel Risenga.
Yeah, I don't know. Can you hear me?
Yes, loud and clear. Thank you.
Okay, I just want to comment on children. I'm a pediatrician.
Okay, cool.
Basically, in children less than 2 years, as he has said, you'll think about bronchiolitis as well as a differential diagnosis. But you also have children that will present with wheezing. We have had a lot of them. When they actually have other congenital abnormalities, such as double aortic arches, right-sided aorta, and vascular rings and slings. So these are the things that you have to think about as well. And then when it comes to doing lung function tests, normally from 5 years onwards, we do train children to actually do lung functions. At the beginning, they don't come out well, but as time goes on, they do quite well. So the other thing is your symptoms and signs and so on, you might not be sure whether it is asthma or not. You actually do a therapeutic trial where you give inhaled corticosteroids for 6 to 8 weeks. And then from there, you'll see if they respond. If they respond, then you stop the treatment. If the symptoms come back, then you restart again. You'll be sure that you are dealing with asthma. Of course, the other thing you would have done your, lung functions. You also have done, skin prick tests and so on, so that you can actually see if there's any allergens. In other words, if they've got, allergic to certain things like house dust mite, cats and dogs. So those are the things that will actually help you in terms of children, to decide on as to whether you should treat them for asthma or not. So I just wanted to
Thank
throw
you.
that in. Thanks.
Thank you.
No, thank you, Samuel. I really appreciate it. I don't know what you hear your thoughts, but I mean, I think maybe also in kids, you'd also probably consider, foreign body aspiration as a cause of maybe a unilateral wheeze. That's something maybe I guess you guys will probably think of as pediatricians.
Yes, that's correct. Yeah.
Thank you, Samuel. Thank you very much. Thank you. Really appreciate it.
Thank you, Doc. Yes. So yeah, we like also to see, I appreciated some of the innovations. Colin Mulaudzi, you'll be next in terms of the live comments, but just going through some of the Q&As here. Bronchial thermoplasty, what an interesting thing, and especially because the effect can last up to 10 years. I mean, that is massive. So is it available in the country, the public sector versus private? Is it something which is here, or it's still novel?
Yeah, so it is available in the country. It's available in state and in private. It's available at Groote Schuur. So Groote Schuur Hospital is the state sector that I'm aware that is doing it. And also the UC private academic hospital. So it definitely is available. I've performed a few myself, and yeah, so it's definitely something it's a treatment modality that is available. It's just making sure that we refer and streamline the correct type of patients, but yeah, it definitely is available. It's not widely available because it requires quite a lot of interventional skills, but it definitely has been in our country now, at least for the past 5 years.
All right, superb. I'm happy to hear that. Just now, theophylline and Montelukast, are these still relevant? When are they used? These are the traditional treatments. Yeah.
Yeah, so theophylline, everywhere else in the world is essentially not being used anymore. And there's lots of problems with the drug. I think it's got bronchodilatory properties. And I think the reason why we still mainly use it is because it's cheap to us. But unfortunately with the drug is that it's got a very narrow therapeutic index, essentially meaning that, your level of reaching side effects profile, which can be a whole lot of things such as tachycardia and things like that, is a bit of a problem. There is no role for theophylline in asthma. Actually, where other people use it will be patients with COPD. But even then, again, we really don't advocate for the use of that. Montelukast, which is a leukotriene receptor antagonist, yes, there is definitely a role for that. And generally, we would actually give these patients in asthma, just basically from your moderate to severe stage, would then start sort of considering using it. Yeah, so it will be for those guys in the moderate to severe.
Yeah, and then there was a question somewhere talking about the phenotype tests that need to be done to classify your patient nicely. Can this be done outside of severe asthma, or they are only indicated in severe asthma?
No, I mean, like this can be, this can be done in outside of severe asthma, but in general, because the number of Th2 high or T2 asthma, majority of asthma is T2, so which is great. So as you know, when you do the skin prick test, when you look at the allergen, you're looking at obviously IgE. But generally, all these patients, what we generally do, even at a clinic level, you can do a full blood count and ask for a differential count. And you look at the eosinophils, and that will help you phenotype your asthma. And it's actually quite good to do that upfront early on, so that when you need to refer your patient across, you've got that evidence. Because usually with time, sometimes the eosinophils, because the patients will have been exposed to steroids and other therapy, might be high, might be low, not really truly reflect.
Yeah.
Of what we're doing, and that's the limitations of blood eosinophils. That's why if we can do it up front, then it's actually best that you do it then. Yeah.
Superb. There's a very basic question. You know, I was asthmatic myself. The last time I had wheeze, I think I was, I don't know, maybe in high school or secondary. Someone is asking if asthma is curable. So, or is it lifelong? Do you think my asthma can still come back? What's your experience on this question? Yeah.
So the way I'll answer the question is to answer it's going the definition. What is asthma? It's a chronic inflammatory condition. Chronic, it doesn't go away, and inflammation is always there. You'll have different times in your life where you'll have more inflammation than not. And that could be obviously various things. Is it seasonal? Is it where you live? Is it where you stay? What other exposures you're exposed to? But unfortunately, it doesn't actually go away, because as we discussed in the previous webinar, the issue is mild asthma. Everybody's got inflammation. So the inflammation never goes away. So you can't outlive it, as most people would think. It's just that your level of inflammation and what triggers it might vary depending on your different age groups. Yeah.
So are you saying I must go and get my inhaler and keep it?
I think you should keep it quite close. Yeah.
Oh, dog. Yeah. All right. Let's leave it at that. Yeah. Someone is asking about ventilator management, and I think that is outside the scope of this talk. I think either early next year or late in the year, we will see. Dr. Yanda will have to come back, and we can look at emergencies in asthma and what we do. Maybe on that particular point, can you then talk to, we saw the stepwise approach, we saw this, but when must we refer? So when should a district doctor or a general practitioner, when do we refer, and do we refer to a pulmonologist or to a physician? How does it work?
Yeah. No, that's a very good question. So generally, I think patients who've got moderate to severe disease need to be referred, and they need to go firstly to a physician. And then the physician will actually help you in terms of, excluding all the other asthma mimics, because most of them are in the general physician domain. And importantly enough, the physician will also have the right link to ensure that the patient gets seen by a specialist pulmonologist. So when to refer? I think if you've got moderate to severe disease, and we've defined it now, that's based on your inhaled corticosteroid dosages. If you've got patients who still have symptoms with that, general physician first, to exclude other secondary causes, who will then obviously have a strong link and will have access to referring your patient to a pulmonologist.
All right. Colin Mulawuzi, you are live on air.
Thank you very much. Look, man, great presentation. My question is a simple one. So where I work, it's around minds, so you have got these patients with mild to moderate asthma who, go for quite some time control, but then they get these exacerbations every time when the air is just a little bit more polluted on the day, and they can't really change their environment, as the factor that affects the environment. So what is your suggested, management plan for those patients who live around mines, who live around, areas which gets dusty sometimes because of the industries? The charge of us.
All right, Colin, thanks a lot, man. Really appreciate your question. And that is a very good question, Colin. So, I mean, the occupation is a significant risk factor for them developing this exacerbation. And as you mentioned, we cannot actually change the circumstances. So what I would generally advise is that what we do for these guys is, and we need to first of all ensure that one, they are always on maximal therapy of their asthma, baseline asthma care, the usual stuff. They're using the stuff properly. They're on the right. They're on the right dosages. And the second thing is obviously we need to just make sure that these patients, don't have asthma plus something else, which could be brought on by the air pollution, especially when the guys go in mines. First of all, they can be at risk of things such as, occupational lung diseases. So we know they've got asthma, but the fact that they've got mine exposure, they actually might be inhaling a lot of dusts, which themselves can actually cause respiratory symptoms, which can exacerbate asthma. Okay, and they can get interstitial lung disease purely by the fact that it's pneumoconiosis, it's silica, it's coal workers, it's platinum, whatever it is. So that's what I would actually advocate, is that we need to just always keep an eye on them in terms of, one, is this just really asthma? Can we need to exclude other things else? And then the other thing is that the guys do underground that they're at risk of is the issue of smoking. And again, having asthma, having exposure to dust, plus smoking. So those are severe sort of risk factors. So I would actually advise that, first of all, if we know that this is really true asthma and they're well controlled and then they get these exacerbations, two things. They'll need chest x-rays. If they have any changes that are not in keeping with asthma, then that's going to assist us in telling us, look, this is actually something else to think about, and exclude other things. And then try and control other sort of exacerbating things, guys smoking around, fires around, and all of those things. So that's where we essentially want to go. And then I think these guys will need to be followed up. I mean, I think, an X-ray every 6 months, sputums, make sure that we exclude tuberculosis. Again, because the miners are perpetually at risk. If mine is at risk of chronic bronchitis, every miner is going to be at risk of chronic bronchitis, which is not really necessarily asthma, but you can get asthmatics who then obviously can also then develop chronic bronchitis. So those are all the things that I would actually advocate that we do. I think you need to make sure that we're dealing with one disease, and we need to exclude other diseases that are potentially there, and make sure that their baseline therapy is adequate. And I think you need to follow them up closely just to make sure that you're not missing any other things.
Superb. And Ephraim Zul is asking a question I was going to ask differently. He's saying, is Symbicort better than Astavent? And I think in responding to the question about the mine, I actually wanted to ask back a question to say, what treatment are you giving? Because when people are continuously exposed to these allergens, they also need to be on appropriate treatment based on current evidence. Would you like to respond to that, Doc? I think it's very important that you reply to this one to remind us on the gold standard treatment at this point.
Yeah, no, thank you very much. So Symbicort is a combination of a LABA, which is a long-acting beta agonist, plus inhaled corticosteroid. Now, what is the issue with asthma? The big problem with asthma is inflammation. Inflammation is essentially the start of all your problems with asthma. It's responsible for your symptoms, it's responsible for your exacerbations. So what do you want to do? You want to make sure whatever therapy you give to a patient with asthma, mild to severe, that you address the inflammation. We do know that inhaled corticosteroids work, but importantly enough, it is not just the inflammation that's a problem in asthma, which is the big component of it. You also need bronchodilation. And that's why the combination of the two, which is what you find in Symbicort, addresses both problems. It addresses the inflammation by the inhaled corticosteroid plus the bronchodilatory effect. However, Astavent is a SABA, which is a short-acting beta agonist. That only addresses the bronchoconstriction, but not the inflammation. And that's the problem, is that most patients, they like using the Astavent, which is a SABA, because they get quick relief. But however, we do know now that the continuous use of SABA only is associated with poor asthma management, and importantly, poor asthma deaths and mortality, because you're not actually addressing the fundamental problem with Astavent. You're only addressing the bronchoconstriction effect and not the main problem, which is the inflammation. And that's what Symbicort does. At least you know your patient is going to get inflammation sorted out, plus they're going to get bronchodilatory effects.
Yeah, colleagues, that is a very important message, and I hope that we have grasped it. I want to give Renelwe, I'm putting you on spot. I just saw your question or your comment on the Q&A. You were talking about the asthma predictive index in children. would you like to maybe tell us more? Sorry if I'm putting you on spot. You may unmute if it's possible. Otherwise, it's still okay. Renelwe Chabele. Renelwe, are you able to unmute? Yes, thank
Hi,
you.
everyone.
Yes.
Yes, I think Prof. Risenga has answered a lot of questions. He's my boss.
So now you can talk after the boss has spoken.
So yeah, like you said, because I understand Ayanda is a physician, but we are pediatricians, and obviously I'm more in Palmo. So what do we do? Like a child comes with this coughing episodes, wheezing, and we usually take 4 whizzes, but our books, we had a prescribed book at med school by our professors. They said any child who's got wheezing episodes, shortness of breath, comes to casualty or maybe in your clinic and you give a bronchodilator and response, is said to have hyperreactive airway / asthma. But obviously, because it's children, they're less than 2 years, like even Ayanda has said, foreign body needs to be excluded. Your vascular rings, your tracheoesophageal fistulas, gastroesophageal reflux diseases, yeah, TB, lymphadenopathy, because most we're still having kids who come in more like asthma, but we find that when you check X-ray, there's a higher lymphadenopathy, mediastinal enlargement, and when you wake up for this TB. So you do the asthma predictive index. It tells you there's family history of asthma, there's your atopy, maybe atopic dermatitis more of, and you've got your eosinophils, you've got your allergic rhinitis. So there's a score that you use, I forgot, so to say, two major, 1 minor, or something like that. Then you use it, and then with it adds more value that it's more even asthma, obviously after having excluded those other causes. And then, like you said, because kids, while you working up for that asthma, obviously not going to leave the child because it responded to your bronchodilators, and we think it might be asthma. We start on what you call the therapeutic trial, where we give you short-acting beta agonists and you have corticosteroid for 2 to 3 months. And then when they come back, obviously you have your results, your milk scans, your CT scans done, and you make sure that you've excluded all the other mimics. And if it is responding to that and you think it's more asthmatic, you continue it. If it's not, then you stop the therapeutic trial.
Yes. Thank you. You must forgive me, Doc, for putting you on spot. But
No, it's okay.
your input is quite valuable. And I know Prof will understand speaking after he has spoken. All right. Thanks for that. All appreciated. Thanks. Maybe Ayanda, as we're nearing a closing, there's a question about long COVID and wheezing, and whether this wheeze should be assessed for asthma. And I think you did speak about COVID and asthma the other time, but I don't know about long COVID and wheezing. Have you experienced this in practice?
Yeah, I mean, I think we haven't really experienced quite a lot of long COVID. And I think in terms of, and I just don't think, we actually, people are really, looking out for the symptoms. But there's a lot of patients who've had COVID who didn't subsequently have developed wheezing. And yeah, I mean, I think it's very important to make sure that we evaluate that, especially if you've never had a wheeze before. Remember, I mean, wheezing is basically a symptom of turbulent airflow, and that could be caused by various things. So it's very important that, especially if you have COVID, I mean, you just want to make sure that you don't have any other thing that might cause you to wheeze, like an interstitial lung disease from COVID. So yeah, so I do think it's something that needs to be evaluated.
Superb. So maybe let me ask, when someone has severe asthma, what is our success rate? Or maybe let me ask it different. What is an acceptable goal? What are we trying to achieve? Is this a wheeze-free period for how long, or how does it work? How do we set goals with our clients? Yeah.
Yeah, no, that's a good question. I mean, any patients with, generally patients with respiratory disease and asthma being one of them, they want to be symptom free, right? Essentially, that's what you want to, that's what you aim for, right? You only aim for patients to be able to improve their quality of life. With severe asthma, you get recurrent exacerbations. You spend a lot of time in hospital. If you're a working person, you're losing out on a lot. If you're a person that's going to school, you're losing out on a lot. And then you get, repeated oral corticosteroids, which then give you all the other side effects. You start gaining weight, you start having hypertension, you start getting infections. So patients just want to actually have good, acceptable quality of life. And what we do is try and make the patient as most functional as possible with their asthma. I don't think you're not going to get away with eliminating asthma, but what you can get away with is giving them an absolutely amazing quality of life. You don't want exacerbations, and you want very, very minimal symptoms. So your symptoms shouldn't be so much that it impairs your quality of life. And I think that's essentially what we aim for.
All right, colleagues, it's exactly 7:15, and I must appreciate you for staying on until this time. We really appreciate you as well, Dr. Ayanda, for always being available to come and empower us. But let me allow you to say your closing remarks, and maybe also remind us of the important principles around how we should care for our patients. And we will then close this session. Thank you.
No, thanks, Lesego. Yeah, no, I think, we've seen in these past two webinars on asthma. I think the mild asthma is by far what most people are going to be managing, be it primary healthcare all the way to district and tertiary. And it's very important that we ensure that, we get our act together with regards to managing with these patients, especially in terms of making sure patients are on a combination of, LABA or long-acting beta agonists and inhaled corticosteroids. You want to minimize symptoms. Make sure that we, really get this information across to our patients, and more than not just our patients, to our prescribers, because we've got a long generation of clinicians who still feel that SARBs are the way to go and still afraid to make sure they give patients combination therapy. We know that Astavent on its own is not a good outcome, so we need to stay away and try and prevent patients from using that. We need to advocate for patients to be having combination of therapy. And then when we're moving on to the moderate to severe asthma, I think once your patient is on that, you need to refer these patients to physicians, and then subsequently these patients will probably end up being seen by pulmonologists. But I do think that what we really need to be doing is focusing most of our attention in the mild asthma. That's the biggest group, and we need to treat that group well.